It's Dr. Leaf, and I'm going to talk about schizophrenia and other thought disorders. These may also be known as psychotic disorders. And so the thing that these all have in common is an element of losing touch with reality and psychotic symptoms or psychosis, right? So if you have your DSM, I think schizophrenia starts on about page 87 or so. That'll bring you to the section. So let's walk through this and see where it goes. So first we start with needing to understand what is psychosis or what is a psychotic state. And psychotic and psychosis is a term that everybody has heard. It's usually in reference to, like, I watched a scary movie about a psycho serial killer, right? Or this person's acting crazy, they're psychotic, right? Well, that in everyday use is just describing probably wild behavior. Clinically, though, psychosis really refers to these 5 symptoms. And most of them, or at least 2 of them, y'all have definitely heard of. Delusions, right? So a delusion is believing something that is not true, right? That it's a belief, it's a thought pattern. It could be, I believe that this person is in love with me. I believe that I am Jesus. I believe that I'm of a different species, right? There's a thought there, a belief that is not true, and because this is really important to distinguish some of these things from cultural norms, the idea or thought I'm having would not fit in with the cultural norms of my culture group, right? So you may have a different cultural client who comes in and they have a value system, a spirituality system that's very different from yours, and you hear it and you think, oh wow, that's a false belief or something. But it is common within their culture, right? We wouldn't diagnose that. So definitely make sure we're not overdiagnosing by assigning delusions to a cultural belief. Now, delusions, that idea it's also a false belief, is really important to distinguish from hallucinations. Hallucinations are when someone experiences something on a sensory level. And so the 2 most common ones are hearing and seeing things that aren't there, right? And so we've all had situations where you think you saw someone, right? You're recording your lecture for your diagnosis class and you feel like you saw someone walk by the window that you're sitting next to, and you turn and you check and nobody's there and you move on, right? Or you thought you heard someone knock at the door, you go and check and nothing's there. These hallucinations, though, or in this context, it's not just mishearing. This would be frequent and chronic, so over a long period of time, it's happening often. It's not happening just once or twice or anything like that. But also, it's the level of tenacity that the client has towards it. Like, no, there is someone in my backyard. No, there is someone knocking on my door. I didn't mishear. I didn't missee. So those are the 2 most common ones. It's not limited to sight and sound. It can definitely be taste, smell, and touch. Those are a little more rare. If the order of how common it is would probably be hearing, seeing, feeling, right? I feel like there's bugs inside of me. I feel like there's machine pieces inside of me. And then smell and taste. Disorganized behavior. So this is their literal behavior, and it's out of sorts. So this is someone who they just start taking off their clothes. It's not goal directed, right? So if someone runs into the street and they start taking off all their clothes, it looks really abnormal, and then they tell you, I fell in an ant hill or something like that, I'm trying to get these ants off of me. That's one thing, right? Or stop, drop, and roll, right? If you saw someone do that, you also saw smoke coming off of them, you'd probably say, hey, they're on fire. And so they're trying to put themselves out. If they just did it randomly for no reason, and they're not acting like a class clown or anything like that, not acting like a goof, they're doing it and it serves no purpose. That's when we start thinking there's some disorganized behavior here. Disorganized speech and thinking, also known as loose associations. So this can be kind of difficult to label, but you would know it when you see it. So this is when they're communicating with you. Stuff doesn't make sense. You ask them, how are you doing today? And they say, I'm doing as well as an enchilada, right? That doesn't mean anything. And well, what does that mean? And they say, well, you know how it goes. And that's disorganized thinking. Or they talk in rhymes. Their conversation is bouncing everywhere. Word salad, right? Their communication is just a bunch of words put together. Neologisms, they're making up words. They go off on tangents. There's magical thinking. Things like that. This would interfere with their ability to communicate. Negative symptoms, negative meaning absent, right? So remember, negative symptoms also showed up in PTSD or the trauma diagnoses. And that meant negative as in low mood, low affect, depressive stuff, dark stuff, right? I feel guilt or shame. Here it means negative as in it's missing. This person shows no affect. This person shows no reaction to stimuli. This person shows no presence, right? They're just kind of vacant. So these are the 5 symptoms of psychosis. And you'll see in the disorders we're going to talk about today, at least one of these is always needed, if not 2 of these is always needed to make the diagnosis. However, you can see right off the bat, looking at these 5 symptoms, that one of the first things you're going to have to rule out is substance use, right? Delusions, right? Someone gets high and they think they're an animal, or there's some grand conspiracy. That can be attributed to paranoia due to, marijuana use. Hallucinations, right? Taking acid or something like that, or LSD can cause those hallucinations. And then disorganized behavior, disorganized speech and all that. Drinking enough can cause some of these things. So one of the very first things we want to rule out is alcohol and substance use or medication use. On a side note, this is also a really good time to talk about, you want to establish their drinking, drugging, and medication history very early on in your work. Doing that as part of your initial intake and saying, tell me about your drinking behavior. How many drinks do you have in a week? Or how many drinks have you had in the last 30 days? However you want to phrase it, getting ahead of it is good. You don't want to be 6 sessions in and they finally start saying to you, well, I have a secret. It's that, the Illuminati is trying to recruit me and I'm going to be the next Messiah, right? So they're kind of explaining a delusion where they start saying things like, I see things that other people can't see and I have these powers. Because then, I promise you, when they bring that up, your first reaction is going to be, tell me about your drinking and drugging. Well, this person has finally decided to communicate this to you, and they say, I'm going to tell you this thing that's been bothering me. I have these powers. I'm very special, or everyone's out to get me. And your response, which is valid, it's just done in an invalid way, is, okay, well, do you drink? Do you smoke? Because you now want to rule it out. However, they're confiding this in you, and now you're asking those questions about drugs and alcohol. What reaction will your client have? Right? They finally trust you enough to tell you this, and they're met with, you want something? right? That's going to shut down your session. So that's why, and I have made that mistake many, many times, and you will too, but I want you to learn from my mistakes and try and do it less, right? So that means at the onset of your counseling relationship, establish a drug, drinking, and medication history. You don't have to spend a lot of time. You can do it on your intake paperwork. You just want to make sure that when they finally disclose this sort of stuff, these wild thoughts or these faulty thoughts and things like that, that you're not going to have to go into a place of making them defend themselves by asking those substance use questions. So let's talk about delusions, right? We talked about hallucinations being, excuse me, being sensory oriented. So there's a couple different types of delusions, and there's probably, globally, there's more than what the DSM lists, but these would be the most common ones. And there is the ability to say there's an unspecified delusion, but most of the time it'll fit into one of these categories. Grandeur, right? So clients believe that they're persons who are really important. And this isn't just like overinflated ego. I would say it's even more than narcissism. This is having otherworldly powers. The world does literally revolve around me. With narcissism, you would typically get, I can do these things. If I'm given a chance, I can do these things. I have done these things. And they're all sort of, they're still grounded in reality. Even if you're saying, like, look, talent-wise, no, I don't think you're going to top the billboards. They could. This one is saying I can part oceans, and I could lift a car clean over my head, right? Things like that. Guilt. I've committed a horrible sin. I've failed. And usually what the pattern looks like for this is they did make some mistake. And I'm even hesitant to say that this might be like they forgot to tip a waiter, or they walked out of the grocery store with an item left in their basket that they didn't pay for. And it's, I'm a thief, my life is over, I'm a horrible person, just tons and tons of guilt. Right? It's horrible. This is unforgivable. My life is over. I'm going to go to hell. I'm going to be eternally punished now. I'll be shunned. Ill health, that they have a terrible disease, just like it sounds. Jealousy, right? So this is the person who they are convinced that their spouse or their partner is being unfaithful. So what do you think we worry about with delusion? Because remember, this is not just someone who is maybe suspicious or paranoid or anything like this. This is happening. There's no doubt in my mind that it's happening. I absolutely know it's happening. You're just doing a really good job at covering your tracks, right? So what would we worry about? Well, aside from it becoming an unhealthy relationship, we would also worry about maybe domestic violence, right? The person gets so jealous that they act out violently, or they do some of the non-violent yet still abusive stuff like gaslighting, stalking, things like that. Passivity. I'm being controlled by someone else, right? What's the age-old one that the government is beaming radio waves into me and they're controlling my behavior. Persecution. Someone keeps messing with me. So if you want a good rabbit hole while we're on the self-isolation thing, look up gang stalking. That is a deep, dark rabbit hole. Lots of really interesting stuff, but these people are out to get me. And so it might be that, so I go outside to take out my trash, put my trash bin by the curb, and I see one of the neighbors walking their dog. Well, she's walking her dog to intimidate me. She's trying to get to me. I go to check my mailbox, and I see someone else checking their mail. Well, they're watching me, right? They want to see what I'm doing. They're out to get me, right? So very much like that that paranoia from the personality disorders. However, this is even further removed from reality. This could be, I saw 2 red cars on the highway while I was driving to my office, and it is some organization trying to mess with me because they know I hate the color red, and so they're putting red cars on the highway to get to me. Poverty, so the extreme saving. So part of this is, one, making sure that the person is not actually living in poverty, right? This is despite having money and stuff, they feel like they're going to go broke, and what happens is they wind up withholding. I'll explain it. They have a child who needs medication. Very famous case study of the miser of Wall Street, if you want to look it up. A lady who had plenty of money, whose child got very sick, and she would not pay for medication or treatment, and eventually I think like a limb had to be amputated and things like that. So although they have that money, they think they're losing it, they think they're poor, or that they might blow through it. This is not the same as penny pinching. It's not even the same as the hit show extreme couponing. This is, I will forego necessary life stuff for fear of losing my money. Delusions of reference. Everything is about them. I'm being talked about on TV. Every time you turn on the TV and you hear, you hear the news anchor say, have a good night. He's talking to me, right? The press is talking about me. Everything is about me. And some of these can be mixed, right? So the persecution. So I might say, every time you see a news anchor touch their face, they're signaling it to me, right? So I did have a client who kind of had a little bit of this, and I'll go into that when we get to delusion disorder. And then thought control, right? Someone's inserting thoughts into my head, right? An idea popped into my head, and it's aliens or the government or whomever has this technology or magical power to just sort of inject a thought into my brain. So delusion disorder, as you can probably guess, revolves around having a delusion. And so really important, this set of diagnoses in this chapter is a lot of has these things and not these things, right? So this is a good example of that. For delusion disorder, the person has delusions and no other symptoms of schizophrenia, right? They have delusions only. They don't have hallucinations. They don't have the negative symptoms. They don't have disorganized behavior, right? It's only delusional disorder. Now, really important, the functions are not markedly impaired. So what that means is the person has a delusion, but they're still able to live their life, right? They still go to work. They still have friends and family. There's not huge consequences, right? There's not a huge impairment. So you might be wondering, well, how does this person wind up there? Well, typically what happens is either A, they get to a point where they say, I need to get some help because they don't understand that they don't think it's a delusion. They're absolutely 100% convinced what they're thinking is true. And they're going to you for help for managing whatever it is they're thinking, right? Help me deal with these people who are out to get me. Or friends and family catch on, or the client discloses to them this stuff, and friends and family say, hey, look, you gotta get some help, right? The behavior is not bizarre. So these are not things like everybody around me is really a robot, right? Bizarre has a very specific definition here. Bizarre clinically means like it would be impossible. Their behavior, it's really, I guess I should specify, their behavior is not bizarre. So they're not going around checking to see your circuit boards, right? They might think you're a robot, but they're not, offering to recharge your batteries or to open up your components and things like that. Their behavior is fine. They don't have that disorganized behavior. And you would specify what type of delusion it is. One, I'm going to skip to the very bottom of the list. Mixed, right? Very common, where it's a couple of these mixed together, or unspecified, where it doesn't fit into this. So, erotomanic, this is where the person is convinced that someone is in love with them or that they're in a relationship with someone, right? So think about what would we, just like with the jealousy delusions, we would worry about domestic violence. What would we worry about with an erotomanic delusion? What we would worry about is stalking, right? So this is what a lot of the celebrities have dealt with, where they've had fans stalk them too much. They're convinced. This is not having a celebrity crush or anything like this. I think Jodie Foster had a very famous case with this. So I mentioned a few minutes ago that I had a client with the reference delusions. So what this person thought was that there was a famous rapper who was on VH1, T.I. She truly believed that she was in a relationship with him. And when he was on the show, and I don't know how long ago this show was on. This was several years ago, on the hit show T.I. and Tiny. And she was convinced that when he was on camera, that was his way of communicating with her. And so what brought her to the office was her daughter, who said, this is not happening, right? And so I met with the daughter one-on-one, and the daughter was saying, she thinks she's in a relationship, and it's not true. And at first this kind of sounds like, well, maybe it's someone who is forever hopeful. And she said, no, it's impossible. She's doing this. She's spending all her money on trying to fly out to wherever this person lives. And so here we have kind of that dovetailing. The erotomanic, that I'm in the relationship with this person, and then the reference one, which we would put under unspecified, he's communicating with me on TV. Grandiose delusions, right? That I can part the sea. I have powers, jealousy, persecution. One that we didn't cover previously was somatic, right? So this is where there is a physical sensation. A somatic delusion would be things like somebody came and removed my organs and replaced them with machine parts. Or I feel bugs crawling all over me. Again, just to reiterate the drug use and substance use assessment thing before you have these conversations, think of like meth, where it is very common for people who use meth to experience the sensation of bugs crawling under their skin. That's why there's a lot of face picking and things like that. So that, again, just another example of, is this an effect of medication or drug use? Bizarre in this section refers to delusions that are implausible, not understandable, they're not from ordinary life experience. So the more fantastic it becomes, the more likely we are to label it as bizarre. So you might be wondering, well, with these delusions, what separates delusions of paranoia from paranoid personality disorder, or some of these delusions from schizotypal, the eccentric one? It's that the personality disorders, those thoughts, those are still grounded in reality. These thoughts that we're talking about today, they would clearly be impossible, right? So That's a really good rule of thumb to help distinguish, is it the personality disorder or is it a thought disorder, is how fantastic are the thoughts. That's not the only rule of thumb. There's also other things that you need to diagnose for personality disorders, and there's other things that you need to have to diagnose the thought disorders, which we're going to cover. So schizophrenia, that's the big one for this chapter. You're looking at least 6 months of symptoms with at least 1 month of active symptoms. And they need to have at least 2 of these symptoms, and at least one of them needs to be delusions, hallucinations, or disorganized behavior, right? You have to have at least one of these 3, right? Now, we would also specify, do they have catatonia? Catatonia is kind of like the panic attack. It's not an independent diagnosis. You have to associate it. And they have 3 of the following. This is in your DSM, and they go over each of these, but things like, are they mute? Are they posturing? Are they always grimacing? Are they saying stuff back to you? Are they making up words? So what's the basic pattern for schizophrenia? We see this usually come on in early adulthood, in that 18 to 26-year-old range. I know that's a pretty big range. What I would take away from that is that that's the age bracket in which most diagnoses come up. It's rare that it happens in children, but it does, and it can. Usually this person, everything's fine, and then when this sets in, that client probably starts just feeling a little off, right? Stuff just doesn't seem to make as much sense, so they start pulling away. This is not a light switch type situation where just one day they wake up with full-blown symptoms. It builds up over time. So by the time they get to you, they've already been rooted in the delusions, the behavior, the hallucinations for quite a bit of time. So during those 6 months, they're pulling away, their behavior becomes odd, friends and family probably start noticing it, less close friends probably start moving on, moving away, you know, that guy's weird, or she does weird things, right? So they start dropping away, client stops engaging in their closer relationships, so those start to end. Those who stick around will start to see the odd behavior and start to worry. So we would expect to see the social stuff go first, and then at work, we'd start to see some of it. So for example, I had a client who lost job after job because he believed that he had telepathy and that he was communicating with people, so he was hearing voices, and he would have full-on conversations while working his jobs, right? So he would be a cashier or a delivery driver, and he would start these conversations where he's not talking to anybody in front of him, and customers would move away, they would complain and stuff, so he lost job after job because he couldn't control this. We would expect to see mood disorders. It is incredibly rare when the thoughts that they have are pleasant, right? Most of the time when someone's hearing thoughts, and even look at the delusions we talked about, they're all pretty negative, right? Except for maybe the grandiosity one. So you've got low mood. There can be quite a bit of substance use, and that's to mitigate the mood and to sometimes quell the hallucinations or the anxiety. Because think if you had that type of paranoia, right, where everybody's out to get you, I would want something to take the edge off. And so that becomes a problem too. This is absolutely something that people can recover from. Not everybody goes back to exactly the way they were before the symptoms came in. This is one that I truly believe this would take a combination of counseling and medication, right? It's going to be a lot of symptom management at the front end, and then it's going to be living with this medication compliance. They start getting into new relationships. How do I disclose this, or do I even need to disclose it? But this is absolutely one that I think benefits from having both medication and talk therapy. Some other, I shouldn't say symptoms, but signs of schizophrenia: the cognitive dysfunction. They look distracted and disoriented. Well, yeah, because they're hearing or seeing things or believing things, right? Think of have you ever gone into an argument with a spouse or a partner or a loved one, and then had to go put on your happy face at work, and you're kind of distracted, you're not on your A game? Well, that's kind of what they're going through, probably on a significantly higher threshold, right? Dysphoria, again, the thoughts they're having, the hallucinations, they are not pleasant, and so that can lead to being angry. I'm angry because everybody's out to get me. I'm angry because people are messing with me. I'm sad because nobody likes me. I'm worthless. I'm guilty. Absence of insight. So this is probably the hardest part of working with schizophrenia and the psychotic disorders, is that they're at the very beginning, right? Session 1 and before session 1, they don't think they're wrong. This is their reality. This is absolutely happening. So this is where that idea comes from. I'm not crazy. You're crazy. How are you not seeing this? Right? So this then becomes, I don't need help. You're part of the problem. I'm not going to take medications. And then, there's always stigma with medication, unfortunately. So that can be difficult. And much like with bipolar, an individual will take medications, the symptoms recede, and then they stop taking the medications because they think they don't need it anymore. And then the symptoms come back and the cycle kind of repeats itself. We would hope that those cycles get shorter and shorter, though. Sleep disturbance, difficulty sleeping, especially when they're in that kind of twilight phase, when they're nodding off and those thoughts start coming in. And then suicide is a very real thing, especially if they have beliefs like, watch, I can shoot myself and I won't get hurt, or the voices are telling me to do it, and then also I just can't take this anymore. The extreme paranoia and unhappiness, right? So a lot of safety planning, a lot of reality testing, giving them skills to cope with these things that we just covered, especially once they get to a point where they're taking medication and starting to recover from symptoms. Here are a few other similar disorders. I'm going to start at the very bottom. Brief psychotic disorder. So this is just like when we talk about PTSD, right? We have the acute stress response, which is not a diagnosis. It's those first couple days after the trauma. Then we have acute stress disorder for 30 days. And then we have PTSD for the 30 days later, right? Brief psychotic disorder is they have at least one psychotic symptom for less than a month. Schizophreniform is just like schizophrenia, except it's less than 6 months. So the person would go to schizophreniform first and then schizophrenia. Schizoaffective disorder. I'm not a big fan of this. There are studies that show that this is the least reliable diagnosis, or it's the one that's given the least reliably. So let's break it down. Schizo, right? So it's in the schizophrenia family, right? The loss of touch with reality. And affective, meaning mood. And so for at least 1 month, clients have had symptoms of schizophrenia, and at the same time, they have also had prominent symptoms of a mood disorder, right? So they don't have quite enough to make a full standalone depression diagnosis, for example. So we kind of put these together. We see this come out a lot of from emergency rooms, right? Emergency rooms will typically, when there's a behavioral concern, the person will get diagnosed with, if there is no drugs and alcohol, a bipolar, a borderline, or a schizoaffective diagnosis. Um, I'm kind of in the camp that thinks you can have schizophrenia and depression at the same time. This diagnosis, though, is just really kind of odd, but it's worth knowing about. But this is one that I have not seen. That's going to do it for the psychotic disorders. I hope this was helpful. If you have any questions, please let me know. Look over those symptoms and let me know any questions or thoughts you have. I hope y'all are doing well, and I will talk to you soon. Bye. Now I got to find the button again. Hang on. Okay, bye.